really excited and grateful that you're able to take the time to be with us today. And if you're not able to be with us today and you're watching this video later on, fantastic that you've also had the opportunity to do that. I'm hoping that I can share with you our vision, our CEIH vision. Together, let's create better healthcare for all South Australians. Before we get started, we'd like to acknowledge that the land we meet on today is the traditional lands of the Kaurna people, and that we respect their relationship with their country, but also like to acknowledge that some of you may be calling in from other lands of other nations, and we'd like to acknowledge and pay respect to those people also. We also acknowledge the Kaurna people, in our instance, as the custodians of the Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. So really our opportunity here is to look at what if the big idea was connecting all of the small ideas. And so in bringing an improvement showcase to South Australian health care providers, what we are hoping to do is really connect people together and help the system share their ideas and share their learnings, share their wins and share their losses, and ultimately bring people together across the system. Our first series, Improving Flow, has taken place over the last 4 weeks, and we have heard from the team down at Flinders around the integrated management system. We've heard from the team at Mowbray, who talked to us about the ambulatory gynecology unit. We were back out at Flinders last week hearing about the Supporting Quality Assertive Discharge program, and we're really excited today to bring the team from the CALHN Day Rehabilitation Service, who'll be talking to us about the Amputee Prehabilitation program. Before I hand over to them, I'd just like to let you know that we've, as we promised last week, we've identified Series 2, and Series 2 will be data in action, so generating actionable insights. More and more each day, we're relying on data to make decisions and influence change, and the challenge is ensuring the data are used to enable innovation and technology, assist in making clinical decisions, developing policies, planning services, and improving and evaluating what we do. And so this Data in Action series will explore how data we used in these experiences to identify a problem and to provide insight and affect the improvement. So actually how the data is used in action. So we're really excited. We'll announce shortly who those guests will be, and really excited to bring that along. Just for background, for those of you who haven't joined us before, the CEIH Improvement Showcase is currently heard, as I said earlier, Thursdays at 1 o'clock, and then online whenever you need to access it, with the purpose of bringing healthcare teams together and providing a space to explore what other people have learned. And really what we're trying to do is keep it simple. So really what you can hold us to account for is if we get too complex, if we try and get too tricky, really this is meant to be a quick session. We've asked the presenters to provide us with a background in a format that tells us about how the need for improvement was identified, for example, how the improvement was designed, and so on and so forth. So we've tried to give some structure to the presentations that you hear about in these sessions so that it's consistent and that you know what sort of message you're going to be getting. The sessions will be sort of 20 minutes of presentation, and at the end of that 20 minutes we will turn off our video recording, and we will then be able to open up the floor for conversation. So just to be clear, if you can keep your microphones on mute during the presentation, cameras on or cameras off, either works from our end. But then at the end of the 20 minutes, we will stop recording the presentation, and we will then be able to open up, and hopefully people will take the opportunity to open up and ask questions and interact with the team that have come to present to us today. One last message before I hand over: if you've got a story to tell, if you've succeeded in solving a problem or perhaps fallen over and broken something trying, we'd really love to hear from you. And also we'd like to hear about themes you'd like us to explore in the future. So this is not for our benefit, it's actually about how we bring the system together and meet the system's needs. So you can contact us at ceih@sa.gov.au or give us a call. So we really look forward to hearing from you. Without further ado, I'd like to hand over to the team down at CALHN Day Rehab. So on our screens, we will be able to see one of the team members, and then we'll be able to be introduced to the rest of the team members throughout the presentation. So if I can hang over to Young Naik, and she will take us through and introduce us to the rest of the Day Rehab service team. Thank you.
Thank you. I'm just going to share my presentation. Okay, well, thank you for the introduction, Katie. So I'm Dr. Siang Naik. I'm a rehabilitation physician and I'm part of the day rehab program. So today we'll be talking about our amputee prehab program. And also with me in the room, I have the rest of the day rehab team. I've got Kimberly Teo, physiotherapy. I've got Kerry Fran from exercise physiology. I've got Tyson Bed as well as Shelley Fulton from occupational therapy, as well as Rebecca Johnston from social work. And we'll all be taking turns talking to the slides. So we would also like to acknowledge this land that we meet on today is the traditional lands for the Kaurna people, and that we respect their spiritual relationship with their country. We also acknowledge the Kaurna people as the custodians of the Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. All right, so I'm gonna kick off our presentation by playing our amputee prehabilitation promotional video. This will take approximately a minute.
The Amputee Prehab program works with clients who are having lower limb amputation and works with them before they have their surgery. The primary aims of the program are to increase confidence, reduce stress before the surgery. Prehab also works with clients to start the education process about what life might look like following their lower limb amputation.
One of the big challenges for amputees is getting them home. So the practicalities of making sure the home is wheelchair accessible and they can look after their daily living tasks and things like that.
Amputee Prehab is particularly unique as it looks at health from a really proactive point of view rather than a reactive point of view.
I had an infection in my right foot that couldn't be cured, so I had the leg amputated from below the knee. It's just the genuine way that the group talks to you, be it about your house, be it about the hospital stay. Initially we were talking 12 to 14 weeks before we were going to be in a position where I'd be up and walking, and I was fortunate enough where I was back 2 weeks after I actually left hospital.
Okay, so taking a few steps backwards to assess how was the need for this program. Okay, so from my point of view, it first started with the amputee nurse support role, and I'll have to credit Erica Krauser, the amputee nurse at the Royal Adelaide Hospital, for the next 3 slides. So it started first in 2017 when the vascular unit at the Royal Adelaide Hospital wrote up a business case to try and increase their allied health services to their unit. And in between February to May 2018, they did a pilot project to try and identify the key issues and delays with their major limb amputees. So these were some of the key findings, but what was really relevant from a rehab point of view was that they found that there was an additional 95 days in the acute setting due to bed block in rehab. These were also some of the other findings. So they thought that there was a lack of governance and no OWI or pathway in place for our major limb amputees. And from a rehab point of view, I have to say that I was definitely aware of a pathway, but obviously it was invisible. And then there was also not a lot of counseling or education. Short and long-term goals were not set with amputees, and there was a lot of issues with isolation and inadequate emotional support. And with these 3 points, we actually do all this in rehab, but obviously it was identified as lacking in the acute system. And then the rehab review also varied, and referral to allied health was inconsistent in the acute setting as well. And I certainly agree with these 2 points. So this led to the birth of the amputee nurse. And it started off with a very simple meeting between vascular and rehab. It was 2 amputee nurses, myself, as well as Brenda, our prosthetist. And we met over coffee, and they presented their findings to myself. And I have to say, I got really excited when I heard these issues, because I knew this was the opportunity for myself to do something about it. I guess I've always been aware that there are inefficiencies in our system, but have always found it quite difficult to implement change. So I certainly took on this opportunity very excitedly. And the first thing I did was to commence an amputee rehab ward round at the Royal Adelaide Hospital twice a week. And because this was something that only involves myself, I could implement it very quickly. The other thing that I did was to have a lot of conversations with relevant stakeholders to essentially highlight the importance of a program as such, and eventually it led to the development of the amputee prehab program that we have now. So if we go backwards again and we look at the traditional pathway post lower limb amputation, a patient would get the amputation in the acute setting, so usually the Royal Adelaide Hospital, and then they would go to inpatient rehab with the goal of learning how to function independently from a wheelchair and to be discharged in a wheelchair. And it is only when their wound is ready do they get to start prosthetic training, and this should be in a community setting with in-day rehab. So this is the ideal pathway, but there are a number of barriers that we often encounter. Firstly, because there's not a lot of rehab involvement in the acute stage. Patients, we found anecdotally that patients were misinformed that they would get their prostheses when they are in inpatient rehab. So, and the other issue that we encounter at the inpatient rehab stage is some discharge planning issues. So often we find it difficult to get patients discharged from inpatient rehab because their home is not wheelchair friendly. So if I go backwards again, now the reason we cannot provide a patient a prosthesis in the early stages is because the wound has to be fully healed before they're allowed to weight bear on a prosthesis, and at minimum this will take 6 weeks. So from a hospital stay point of view, this is a really long time, and we can't be keeping patients in hospital for this long. So on one hand, we have a patient who's been misinformed and expects to get their prosthesis before they're discharged rather than being discharged in a wheelchair. But for clinical reasons, we're unable to give them a prosthesis any earlier. So these patients need to be discharged functioning from a wheelchair, and this leads to the next problem where the patient then needs to have a home that's wheelchair friendly. But most Australian homes are not wheelchair friendly by default. So because we have an issue with the patient wanting to stay, and then we have a practical issue with accommodation, the patients end up staying in inpatient rehab while their home is being modified. So understandably, this increases their length of stay, and this creates a bed block situation between rehab and discharge to community, which then in turn causes bed block in the acute setting. So this is not such a hypothetical conversation between a surgeon and a patient, or a vascular surgeon and a patient. So the surgeon will say to the patient, your leg is unsalvageable, and the only thing we can offer you is amputation. And the patient goes ahead and says, go ahead, thank you for your generous offer. But this almost never happens. There's not ever a single patient who says straight away, yes, you can amputate my leg. So the thing is, as clinicians, we know that the amputation is inevitable, and between the time that the patient refuses the amputation to the time that they actually get the amputation, there's actually something we can do. And this is where prehab comes in. So right now, when a patient has been identified to require a lower limb amputation, they're referred to our program. And a lot of our program involves education. And I'm not going to go into this in too much detail because the rest of the team will be talking about it. And a very important part of the prehab program is that a home visit is done to assess whether the house is wheelchair friendly. And if not, what are we going to do about it? Are we going to modify it, or are we going to start looking for alternate accommodation before the amputation even happens? And we're able to achieve this prehab program, or we'll complete the program within 3 weeks, and the patient will undergo this or have the amputation delayed, provided the amputation is not critical. And if we think about it in community talk, 3 weeks is pretty good. It's not really a long time. But if we look at it from an acute setting, 3 weeks is a long time. And we have a lot of complex decisions or complex conversations with patients so that they can make these really hard decisions. And doing it before the amputation means that they actually have a bit more time, plus they're actually in the correct frame of mind to think of these really hard decisions. However, in an acute setting, patients don't really have that sort of luxury. So the idea is doing all this before the amputation even occurs. So what we did was then to to put a patient through a prehabilitation program before the amputation. And what we found is that most patients are able to be discharged directly home from the Royal Adelaide Hospital with rehab in the home, bypassing inpatient rehab altogether. And the average length of stay in inpatient rehab for an amputee is 30 days. So instantly, we've already shaved at least 30 days off an inpatient admission. And we'll talk about this more in a couple of slides. And we found that other than the fact that the patients had a shorter length of stay, because they were more prepared for the procedure as well, they returned to independence more quickly, and there was also a high level of satisfaction. Okay, so now I'm going to hand over to Tyson.
Thank you, Siang. Things up here. Hi everyone, I'm Tyson. I'm an occupational therapist involved in the program of Prehab. So I'm here to talk about improvement and design of the program. I'll go through these points here, but as you've already heard, the day rehab is a multidisciplinary approach. So each discipline involved provides tailored education on relevant factors that are related to amputation. So this begins a multifaceted process, physical conditioning and practical considerations in preparation for an amputation for clients. So it's that education is something that is really key for what we're trying to do here. So just some examples of some multi-D input, and this is not an exhaustive list of what we do by any means, but just a bit of a snapshot. So rehab medicine provides specifics around medical treatment that's going to be required and what to expect. Nursing might look at wound management and what to expect in that regard. Physiotherapy, we'll talk about expectations for amputee rehabilitation and prosthetic training. The exercise physiologist will start working on physical conditioning in preparation for the amputation. Orthotics and prosthetics will start a discussion around, prosthetic training and some of the expectations and the pathways that need to be taken. Occupational therapy discusses functional independence after an amputation and what they will be expecting. And it addresses, like Siang said, those really significant environmental factors, especially in and around the home, because their functional status, being in a wheelchair, is going to be impacted significantly. Social worker will get involved to, start that conversation around, emotional preparation and how someone's sitting with the idea of having a limb amputated and how they're going to respond to that amputation. And then finally, dietetics would look at things like nutritional adequacy prior to surgery, nutrition for wound healing, and perhaps even management of chronic disease such as diabetes, which is so prevalent in this cohort. So within the day rehab design, we kind of informally had what we called champions. So there's a few sort of key players in each discipline that had a special interest in prehab, and they were an informal representative who would keep an eye on each prehab client and sort of be a point of call for any issues that may come up. So to the next point, within existing resources. So given the small scale of the prehab project, it was able to be incorporated within our current staffing structure that was available to us. So we didn't have any additional staff or any additional funding. So the nature of this being a feasibility study, it would have been really difficult to obtain additional resources given the uncertain nature of the outcomes. We thought we knew what the outcomes would be, but we couldn't be certain of that until we gave it a go. So for this reason, rolling out the prehab program was an organic process and needed to be very adaptive and responsive to the needs at hand. And that's sort of something you'll hear over and over again with our presentation today. The next point, engagement with stakeholders, is obviously really important. So this included, but isn't an exhaustive list once again, liaison with medical colleagues, different departments, things like that, liaison with allied health colleagues across different areas and departments, and getting feedback from clients about, what was working and what they, their impressions on the program. So this is how we worked from a principle of co-design for our prehab program. The next point, innovation. So there's a lack of evidence for this cohort and for the prehabilitation process in general. Basically, it just hasn't been done before. So we were challenged to change the way we think about this cohort. So essentially, we are working in a proactive manner instead of a reactive manner. So this is different to the standard approach to many areas of health, but certainly to rehab in general. We also looked at, in preparation for prehab, we looked at evidence from other diagnostic groups, for example, cancer services and orthopedics, to assist with formulating our approach, because they have some similar ways of getting involved early. The last point, research. So we set up prehab so that outcomes could be measured and evaluated. But essentially, we just started really small and trialed as we went along. And it built and developed on a single case rather than starting as a large scale project. I just have a small case example. So we had a man a number of months ago, and he attended his prehab clinic appointments in the clinic setting. And then after that, he'd already met with the occupational therapist. So after that, we booked in an OT home visit prior to his amputation. And from going through this process, both in the clinic and then at his home, it became really clear that there were significant social and housing issues, environmental housing issues, that would make it really hard for him to return to that house. So we were able to identify that really early. Ultimately, this man, our hunch was right, and he didn't do so well in his prosthetic training and recovery and all of that sort of thing. So he really hasn't so far progressed very far with his rehab and prosthetic training. However, because we started the prehab process and we identified all these things, as the occupational therapist in particular, we could see the home, and then we could document those issues and send a report to Housing SA, which actually enabled him to get a new house and be relocated into a new house and go straight from the acute setting into that new house, which is a small example, but it's really an example of a somewhat unforeseen way that we've really assisted with the flow of patients through the system. But if he'd gone through the standard route, all of those issues wouldn't have been identified until he'd already had his leg off. So although he hasn't gone through the rehabilitation process as smoothly and as nicely as we would have liked, it really has helped with that flow and discharge planning and length of stay and all of those things that we're really aiming for. So my two take-home points take-home points for today really is we started really small and we built on our experiences as we went along. And this allowed us to trial, adapt, and then respond as required. So we learned what we're doing as we went along. Just trying to find the next slide. So our outcomes. So we've actually submitted a research paper for publication that evaluates our prehab program. The aim of this research is to compare hospital length of stay and discharge destinations between patients receiving or not receiving prehabilitation prior to major lower limb amputation. The design was retrospective and used matched pairs of clients, and it was a case-controlled study. So if you look at the graphs that are on the screen here, so you've got the acute hospital length of stay, the rehab hospital length of stay, and then on the far right, the total length of stay. The solid bars represent the prehab cohort, and the hatched bars represent the control or the standard care cohort, so the clients that didn't go through the prehab process. Just from this snapshot, you can see that there are marked reductions in the rehab length of stay, which is the middle section, for the prehab clients, and then that impacted on the total length of stay significantly as well. So from our results, we can say that the total hospital length of stay for the prehab group was 6 days versus 37 days for the control group. Thank you. I'm just going to hand over to my colleague.
Hello, I'm Rebecca from Social Work. Thanks, Tyson. So I'll just be looking at some of the psychosocial impacts here. What we acknowledge from a social work psychology point of view was the importance of early assessment to really help with that, making that acute hospital stay less. So we're getting in there early, we're doing that psychosocial assessment, and we're looking at the person and environment and really to see, you know, their preparation for loss. This is kind of the early stages of how they're going to react to loss, how family are going to react to loss, the person in their environment, who's around them, who are their supports. And this can really help us. What we can do then is once we have this initial assessment, we can feed that upstream. So we're already ahead by starting that early assessment. So further upstream, the social workers or whatever allied health staff, medical staff will know that about that person in the environment and who's around them and supports. And also when we look at a practical level, the early initiation of services like NDIS, Limbs for Life, Carers SA, Centrelink, all early connections to those services, rather than leaving them like right at the end when it's that push for discharge, push to get out, and they might not have already connected with those services. We want to get those services in early to start supporting them and family. You know, the main thing we really look at too is when an amputee first comes into us in social work is a lot of the time we're dealing with anticipatory loss. So, you know, it's anticipating the loss of a limb, but also the loss of a role, the loss of a lifestyle, possibly loss of employment, so many things. So we're kind of looking at the person's reaction to that, but also carers' reaction, and getting in early with those relationships as well, or communicating with workplaces or connecting family to Carers SA or Limbs for Life, just so there's some support there. The loss and grief is a journey with amputees. So, and there's stages of loss. You know, there could be anger, bargaining, crying, all sorts of things, and that will change throughout the amputation process. So it's just acknowledging, giving them a little bit of education about grief and loss as well, and to normalise what they're feeling, because it's going to be, you know, a big impact on their life. Also, which I guess that kind of comes into normalising, you know, expectations as well, you know, providing education on accepting and adapting, reassure them that they're going to have ongoing relationships with us. I think sometimes in the healthcare system, especially acute, you know, you might just see someone and then you're discharged or whatever. We can say to them, we're going to see you at the beginning of the journey, like at the pre, and we're going to be there on the other side. So to reassure them that they'll see the same face on the other side. So it creates, you know, some consistency in the journey of relationships and trust as well. And then we look at, you know, and what I say to amputees is, to be honest, I don't know what it's like to lose a leg. So it's that thing of saying, well, how would you feel about talking to another amputee? Someone who's had a lived experience, are they ready for that? They might not be, and that's fine, but they might be ready at, you know, the end of the journey or the end of acute. So we can give them information on services such as Limbs for Life. So it's just getting in early, just to do that early assessment for the preparation of the upcoming loss. And these are just some of the patient feedback that we've had along the way. So, you know, some people have had, having the same people involved in my rehab after the operation was the most useful thing. So again, it's that consistency of relationships. If I didn't have prehab, I wouldn't have known anything about my amputation. So again, it's, you know, all of us allied health and medical providing education and normalising that experience. Without prehab, I wouldn't have known what equipment was needed. that's education in itself, because how would you know the equipment when you've never experienced it? And it helped me to understand the hospital and surgery process. So just knowing some of those pathways, we can normalise a little bit about what to expect and expectations. So now I'll just hand over back to Sian.
Thank you, Rebecca. Right, so lessons about improvement. So what did we learn? So the first point is to be flexible. As already mentioned, that we undertook this with existing resources, and the idea is to, I guess, be open to what we can do despite not having any extra funding or any extra staff, and just being innovative with what we've got. Quick wins as well, try not to belittle them. It doesn't matter if it's maybe a reduction in length of stay of 1 day. A day's length of stay is $1,500 in hospital, and you start somewhere and you keep going. Ongoing refinement of the project, again, as already discussed, we started with just one patient, and then we continued to learn from that, and with subsequent patients as well, continuing to improve what we do. Champions cannot be underestimated as well. For any project that you want to undertake, not only is important for there to be champions to see the project through, but to sustain the project. The champions to sustain the project is also really important. As an example, if one or two of us go on leave, we actually notice a difference in the pathway and a difference in the length of stay. Communication, again, that's a very broad communication broadly with our patients, to receive feedback from them, to see how we can improve what we're doing. Again, communication with our relevant stakeholders to see if there's anything we can improve, and of course communication within the team as well. Right, so that's the end of the presentation, so we're ready for questions.
Fabulous. Thank you so much to the whole team for that presentation. That was fantastic. We'd certainly like to open up the floor to the people who have joined us in the call, and give you the opportunity to ask the team questions. You can use the chat function if you'd like to, but it'd be great if you're happy to turn on your cameras. We will stop recording the session now, if we can, please, team.